So the second part I would like to introduce is the normal developed EEG in the infant and children. And the pediatric EEG is also very different from the adult EEG, because the EEG in children is very complex waveform and frequency change in children, and they also present with a age-dependent waveform change, and between individual has a high variation, and we needed to consider, because the children usually come for the EEG examination, they are very sleepy because we usually order a EEG recording, and they come to our lab usually really drowsy and sleepiness. So at this time of waveform, probably we needed to be very cautious to interpretation. And high variety of the EEG change while children with drowsiness. So when the EEG is awake EEG in children, the background activity, when we do the visual attenuation in a very young patient, we can block eyes by technician hands, or if they cannot cooperate very well. But the background activity is not very prominent before 3 months of gestation while they are eye opening. So the frequency of the awake EEG in 3 months old is around 3 to 4 Hz, and before 3 months old, usually no dominant of occipital area, usually central, and mainly symmetrical over central and parietal. At 5 months old, usually will have some theta activity like 5 Hz and start to have posterior dominant. For the 1 year old, the background probably reach to 6 to 7 Hz, and 3 year old is about 7 to 8 Hz, and the 7 year old can reach alpha Hz at 8 to 9 Hz. At 10 years old is about 10 Hz. 15 year olds, the background will around 10 Hz. But in the mid-50 adult, the frequency will decrease. So this is the infant, and this toddler children will increase the frequency until adult, but the old patient will decrease later. So this is a newborn baby, but before 3 months, usually there's no occipital dominant, but the background will be a parietal central area. But in the 1 year old infant, the background appeared on the posterior region, and the 5 will have some alpha rhythm can be observed. And the 10 year, you can find 9 to 10 Hz of background, alpha background, which is very well. Sometimes will have intermixed with some theta activity, which is normal. And then the 15-year-old usually have very sinusoid alpha activity over the posterior head region, but in the very old people, the background activity will decrease. And the alpha frequency, as you can see this table, will increase. Age-dependent change will increase the frequency when they grow up, and amplitude also higher in the children. And the amplitude, when they were very young, like 1 month old, is very low. Like we say, a newborn baby, actually, when they awake, they will active moyan is a very low voltage LVI, irregular pattern. And when they reach 6 to 12 months, the amplitude will go up to 30 to 100 microvolts, and the 2 years old is around 50 to 80 microvolts, and 3 to 15 years old the amplitude will increase up to 30 to 100 microvolts. In 9% of normal children, the amplitude will be more than 100 microvolts, which is normal. And usually we can accept a normal asymmetry amplitude. For example, 20% difference of the right side and left side asymmetry, which is normal. Usually higher amplitude over right side. When we consider the voltage difference is abnormal, is more than 50% of the amplitude difference, we will call it abnormal. And for the frequency is you can see the asymmetrical around 1 to 1.5 Hertz, which is acceptable. And for example, this is a month-old infant, and we can see the theta range when the baby was awake. Usually the theta range is in the middle or posterior head region, which is normal. And when they drowsiness, and it will show very prominent rhythmic theta activity, high voltage bisynchronous theta activity. And when they sleep, before 2 years old, we will see some sleep spindle, asynchronous sleep spindle, which is also the normal. And when they reach like 12 years old child, and they will have very good alpha background, but alpha background sometimes will intermix with a slow activity to 1 to 2 Hertz, which is also normal. And we will see some theta activity over central area, which is also normal in a young age of child. And the sleep also show the generalized high voltage synchronous slow wave and V wave and sleep spindle. And in the young age of children, the youth, we will see many EEG of posterior, with the posterior slow wave of youth. When they were awake, we will see the background alpha activity intermixed with some slow wave. This is posterior slow wave of youth, which is normal. Again, you can see here and here. And it is appeared rarely before 2 years old or after 21 years old. Frequently disappeared between 8 to 14. Frequently appear between 8 to 14 years of age, and the frequency is around 3 to 5 Hertz. And this is the often appear on the posterior occipital area, and the wave will blocked with eye open. The mu rhythm also appeared in children around 8 to 16 years old, and gradually increase the frequency to adulthood. So not necessary to be symmetrical. When we see the right side central area has mu rhythm, and we usually can ask the patient to wiggle their contralateral thumb or hands will block the mu rhythm. And lambda activity also appeared in children in 2 to 15 years old, and also can be asymmetry, usually looking at the ceiling or pattern. At this time, we can ask the patient to look at the background, not pattern, and also dim the light. And this is caused by a saccade eye movement. So the response of activation procedure also age-dependent. We will talk about the photic stimulation, hyperventilation, sleep arousal. And when we do the photic stimulation or eye open close, and the infant over 3 months of age, we can use the passive eye close by placing technician's hand over patient's eyes. Will successfully produce the dominant posterior rhythm. And then we do the photic stimulation at least at 1 to 20 flash per second. The photic stimulation, children also have many patients will have harmonic or subharmonic photic driving. If this asymmetry, we will consider it as abnormal. And photomyoclonic response usually disappeared after photic stimulation stop, and it will cause eye or neck or muscle reflex. This can be normal. And photoparoxysmal response usually appeared after photic stimulation a few minutes and continue even after stopped photic stimulation. But as we mentioned, we needed to know the photoparoxysmal response. It can be appeared in normal population around 10 to 15%. And also, we saw a lot of patients has no apparent response after photic stimulation. So this is the normal photic stimulation on the background rhythmic photic driving response. And this is the photoparoxysmal response is after at 6 Hz of photic stimulation in a 12 years old girl with diagnosis of JME, juvenile myoclonic epilepsy. Usually, the general spike will induce after photic stimulation. And the photomyoclonic or photomyogenic response is happened only when photic driving. When the photic driving stop and the myoclonic response stop too. And this is the eye fluttering while photic stimulation. Hyperventilation is also have age-dependent change. We can attempt after 2 years of age by asking patient blow out the candle or celluloid windmill or blue handkerchief. But we do recommend to do hyperventilation every person after 4 years of age. We can ask the patient to do deep breathing to 20 to 30 minutes for 3 minutes. In absent seizure case, we can do 4 minutes of absent seizure. And moya disease, usually only 1 minute because there's a risk of build up and will cause the patient have stroke, TIA, or extreme hyperventilation because of vasospasm. And the build-up slow wave characteristically is greater in children and adults. The build-up slow wave, particularly in patients around 10 to 12 years old. The quantity of slow wave depends primarily in the degree of hypocapnia and the blood sugar level. So this is the 8-year-old boy with marked hyperventilation effort. This is actually normal in children by very synchronous high voltage 2 to 3 Hz slow waves. And this is the usually hyperventilation reaction has a very big range in between individuals. And then we only interpret it as abnormal only present with spike and slow wave or sharp and slow wave or very clear one-side change or focal change. We will consider abnormal. And usually we will record hyperventilation at least 6 minutes after hyperventilation effort. And the hyperventilation usually when the patient younger than 7 years of age, it appeared posterior build up, posterior slow wave. After 7 to 5 years, especially adult, will be anterior part have more slow wave of the build up. Usually when we do the hyperventilation, within 1 minute, around 6 seconds, will gradually become normal with no longer slow wave, unless the definite spikes and are mixed with some spike and slow wave will continues present. So we only consider the focal slowing or epileptic phone discharge or as abnormal. So this is the normal patient in a 4-year-old boy with a posterior high voltage slow wave built up after hyperventilation. And this is the 8-year-old girl with moya disease. And we can see here, before hyperventilation has a slow wave over the left side hemisphere, and during hyperventilation about 25 minutes, it shows high voltage slow wave over the right side hemisphere. And just stop the hyperventilation, still show a very high voltage slow wave, but gradually slow down. But after stop hyperventilation 2 minutes, 2 minutes after hyperventilation, rebuild up again. At this time, the patient complained she had the dizziness. So when we do the hyperventilation in moya disease, we need to be very careful. So the maturation of the EEG is also age-dependent change we summarize in this table. And the background, as we know, gradually increase the FR rhythm. It actually appear in 5 years old and reach 10 in 10 years old. And slow wave while awake is considerable before 3 years old. And in school age or preschool age of children, markedly admixed with posterior slow, which is normal, and variant degree of posterior slow wave with alpha, which is normal as well. And this is hyperventilation and photic stimulation response in different age group for your reference. And the next topic will be some pitfall of the specific normal waveform variation I like to introduce happening in the children. First is 14 and 6 Hz positive burst, usually appeared in 3 to 4 years old, but maximally expressed in adolescent, particularly in 13 to 14 years old, and then gradually decreased incidence with age. Usually appeared with rhythmic trends of arc-shaped positive spike-like component with a negative smooth round-shaped component in reference montage. And in the 14 or 6 to 7 Hz in burst in a duration of 0.5 to 1 second, the amplitude is very low. It's less than 75 microvolts, and the location is around the posterior temporal region, and it could be independent or one side or asynchronous. And the second is rhythmic temporal theta burst of drowsiness, which usually happen drowsiness and very spiky, and we call it psychomotor variants, and sharply contoured like a sharp wave, and easy to misinterpret is a spike. Usually this rhythmic temporal theta burst is about 5 to 7 Hz over mid-temporal area. It could be independent or bilaterally or shift from one side to the other side. And the sleep EEG also has some pitfalls. Usually is diffuse rhythmic to sinusoid theta waves, and less often to see is generalized by synchronous burst. And the rhythmic to sinusoid high voltage wave exceeds 300 microvolt, usually seen 3 to 5 infant occipital area. And the beta activity usually occurred in 5 to 6 months of age. And when the sleep onset or drowsiness, usually hypnagogic hypersynchrony will appear in 3 months of infant, and it appeared more commonly in 1 year old. And in the 4 to 9 year old children, there's a paroxysmal hypnagogic hypersynchrony. It's happened very often. We need to know this is not generalized spikes. And the hypnagogic hypersynchrony will disappear until 13-year-old. So this is the hypnagogic hypersynchrony you can see in a 6-month-old infant. And this is also the hypnagogic hypersynchrony in the 6 years of girl. And this is paroxysmal hypnagogic hypersynchrony in a 4-year and 4-month child. And the positive occipital chop transient post is also easy to misinterpret as a sharp wave or epileptic spikes. This is happen usually after 5 years of age and disappeared about the mid-10s. As you can see, usually the occipital, when the stage 1 sleep usually happen in the occipital area, is usually when we do the reference montage is downward, is positive. So we call it positive occipital sharp transient. So you can see here in a 5-year-old boy, you can see the post here. Sometimes biphasic, sometimes it goes down, and when we do the A1, A2 referential montage, usually goes down. And the vertex sharp transient is also a pitfall of the EEG reading in children. And in the 5 months of age, usually already gradually appeared in vertex sharp transient. And the most prominent will be 3 to 4 years. And the amplitude of vortex sharp transient usually very big, larger compared to the adult. But it can be positive, negative, or biphasic, and could be shifting and asymmetry. In 2 to 4 years of children, it can be very high amplitude and repetitive vertex sharp transient. For example, like this one looks like continuous spike and wave, but actually this is a vertex sharp transient. It could be very spiky and repetitive. And this is a 4-year-old child, and you can show the sharp contour of the vertex sharp transient, which is normal too. And the split spindle also has edge-dependent change, and the distribution mainly in the central area, could be the midline, and parietal, it could be the frontal too. At the 2 months of age, the spindle gradually developed, and 3 to 9 months of age, very prominent slip spindle in the stage 2 sleeps. But when they reach like 1.5 years old to 3 years old, they will become less often of split spindles. The duration of slip spindle could be as long as 1.5 to 1.8 seconds in a 4 to 6 months of infant, and could be very long to 3 to 4 seconds. And when they grow up, and then gradually the duration will gradually decrease to the 0.5 to 0.6 seconds. So the frequency of slip spindle will gradually increase by age. In the 4 to 5 years old, it would be 13 to 14 hertz, and could be synchronous or asynchronous, especially in very young children. It could be a very high, very spiky slip spindle, easily to confused with seizure discharge. And usually we say the abnormal slip spindle, we will consider there's no slip spindle until 3 months of age. And the voltage difference after 2 years more than 50%, or prolonged spindle in non-REM sleep usually occurred in mental retardation, brain injury, or autism. Hypothyroidism infants sometimes will show the reduced number of sleep spindle. In 3 to 12 years old children also have high amplitude or frontal dominant or sharp contoured sleep spindle. The frequency could be 10 to 12 Hz, different from adults. And this is a normal sleep spindle in 5 months of baby, and could be symmetrical, asynchronous, could be asynchronous. And this is abnormal because there's absence of spindles when this baby is 5 months old. And this is asynchronous spindle at 8 months of baby, which is normal. But if you see this kind of spindle after age 2, we will call it abnormal. And this is a prolonged spindle or extreme spindle, and this is usually associated with mental retardation or autism. We will consider this is abnormal spindle. And K complexes usually develop at 5 months of age. And this is the arousal. When the arousal before 2 months of age, the amplitude will become smaller, become decrease or decrescendo of amplitude. And the 2 to 5 months old will have some rudimentary or biphasic delta wave when they arousal. When the 6 months to 5 to 6 years old, the arousal will induce 4 to 5 Hz rhythmic spindle and persistent to 5 to 30 seconds. And post-arousal hypersynchrony will appear in the frontal and central, could be very high voltage regular theta wave. And this is arousal-induced hypersynchronous slow wave, which is normal. And this is the EEG change timeline of the different waveform, like intermittent slow wave. It appeared in 6 months, and suppression of voltage is 5 months when they were drowsy. And light sleep, the hypnagogic hypersynchrony will appear at 4 months, and sleep spindle is about 2 months. Vertic sharp will appear 5 months, and K complex also appear in the 5 months. And the deep sleep, we talk about this tracé alternance will appear in the newborn and disappeared before 2 months. And the arousal response we just mentioned about the arousal will become high voltage at 4 months of age. So this is the table. Sorry about the Chinese character here, but this is the table of the background activity gradual, the developmental of gradual, the background rhythm, and the slow wave appeared in the awake, which is normal in children, and hyperventilation response, usually marked response between 4 to 12 years old. And the photic driving response will have age-dependent change too. And this is the sleep stage, how they have developmental change, age-dependent change. So that's it. Thank you for your attention.